All right, and now we start Chapter 12, Hormonal Disorders. We're going to start out with precocious puberty. Here's our case. A 6-year-old girl is brought to the office by her mother who has noticed breast budding and pubic hair development on her daughter, a 6-year-old. Her childhood history is unremarkable until 3 months ago when these changes began. The lower limits of pubertal development in a girl is age 8. In a boy, it is age 9. So clearly, this girl is below that 6-year-old girl. When we look at the causes, our differential diagnosis is listed here. The most common by far is idiopathic. Idiopathic means that there is just an awakening of the hypothalamic pituitary ovarian axis earlier than normal. Now, what are the factors that normally stimulate the ovarian hypothalamic pituitary axis? What is it that brings about the onset of puberty? It's not entirely known for sure. There's clearly been a change over the years, the last 100 years. There's been a decrease in the age of puberty. We'll talk about that more later. Idiopathic is by far the most common. Then we have CNS pathology, which stimulates the hypothalamic pituitary hormones as well. The last two, granulosa cell tumor and McCune-Albright syndrome, have low gonadotropins, and they are rare, unusual causes. They're called gonadotropin-independent precocious puberty. Okay, this is what we're going to end up with at the end of this section. Let's first go through it. This is a Time magazine article from 2000 looking at early puberty. Why girls are growing up faster? Is it the hormones? Is it the fat? Is it something in the water? Why? And clearly, pubertal changes are occurring earlier in girls than they used to. Diagnosis: female secondary sexual characteristics, accelerated growth in a girl that is less than 8 years of age. Okay, for the board exam, what you should know is these following landmarks in pubertal development. The earliest is thelarchy, which is breast development, usually occurs age 9 to 10, and they're usually in this sequence. This is followed by adrenarchy, pubic and axillary hair. This is under the development of, or under the stimulation of androgens. Breast development is estrogens. Adrenarchy occurs age 10 to 11. Then we have the maximal growth spurt, which occurs at ages 11 to 12. And then there is the first menses, which is age 12 to 13. So put that into your hard disk someplace where you can access it for the exam. This shows what has happened to the age of menarche over the last 150 years. And you can see that in 1840s, the age of the first menstrual period was 16 to 17 years of age. Now we're down to 12 to 13. This is in your notes, and it shows the sequence of development: breast development, pubic and axillary hair, the growth spurt, and then menstruation someplace between 12 to 13 years of age. This figure shows it very nicely. This looks at the height increment per year in growth with year 1, 2, 3, and so on. And you can see that in childhood, obviously, there's a lot of growth that occurs. Then we have a low latent years, which is very slow growth, which is about age 8 to 10. Here we have thelarchy occurring at about 10 to 11. We have pubarchy around 11 to 12. We have the first menstrual period, 12 to 13. And I want you to notice the maximal growth spurt is right here. By the time her first period has begun, she has already started to decelerate and slow down in her growth. And this is the big concern with precocious puberty. Not that there is any problem with fertility, not that there is any problem in sexual functioning. It is that there is premature closure of the epiphyses of the long bones because of the early estrogen. And once you start that closure, it's going to be very rapid. You can see by age 14, basically all growth has taken place. Notice the ovulation, regular ovulation, is around 14 to 15. So it takes about 2 years from the onset of the first period to where you have regular ovulation. We can talk about complete precocious puberty and incomplete precocious puberty. Incomplete is where you have either breast budding or pubic and axillary hair or vaginal bleeding, but not all three. Complete is where you have all of these which occur. Incomplete is felt to be either because of low receptor sensitivity or because of transient hormone levels, and the management is conservative. For instance, a girl may have a low sensitivity for estrogen in her breasts and may have then even the low levels of estrogen in childhood may be enough to stimulate breast budding. But if there's no other changes, we should not have enough to close the distal epiphyses of the bones. We will talk about each of the possible causes with complete precocious puberty coming up right now. We can divide precocious puberty into either gonadotropin-dependent or gonadotropin-independent. Gonadotropin-dependent is mediated through a rise in FSH, which is stimulated by a rise in GnRH. We have increased estrogen from the ovaries due to premature gonadotropin hormone-releasing hormone and FSH. This is the cause of idiopathic, which is the most frequent one that we see. This is also known as constitutional. Age is typically age 6 or 7, and MRI of the head is normal. We'll talk about that in just a minute. The management is to try to suppress the gonadotropin-releasing hormone, and we can do that with GnRH agonists. They initially will stimulate, and then they will bind to the receptors, so you have no further stimulation. See, GnRH is usually secreted in a pulsatile fashion. This is a continuous. Now, what's interesting is that blind girls develop puberty later than girls who are sighted. There may be something about the light-dark cycles. We know that girls who live in northern climates, like in the Scandinavian countries, have onset of puberty later than girls who live in the Mediterranean area. It may be that body weight, the percentage of body fat, has something to do with it. But anyway, idiopathic, we really don't understand why. It is just the premature activation of a normal hypothalamic pituitary gonadal axis. So we basically suppress the FSH and lower the estrogens until she reaches a certain either height or chronological age or emotional social maturity. This is usually managed by pediatric endocrinologists. Another cause, although it is rare, of gonadotropin-dependent precocious puberty is CNS pathology. There's some CNS lesion which stimulates the premature release of gonadotropins. The MRI is abnormal. It could be because of a tumor, because of sarcoid. It could be because of hydrocephalus. And the management will vary depending on whatever the lesion is. This is usually managed by neurologists or neurosurgeons. Then we have gonadotropin independent. Normally, FSH levels are low in childhood, and they are not raised in this situation. There is increased estrogen from autonomous ovarian production. The ovarian follicles are not being stimulated by FSH. Why would they then be stimulated to secrete estrogen? McCune-Albright syndrome, also known as polyostotic fibrous dysplasia, has, for reasons not entirely clear, autonomous production of estrogen. On physical exam, you will see brown, café au lait skin spots. This is 5% of all precocity, so it is unusual. And the management is aromatase enzyme inhibitors. And remember, the aromatase enzyme is what converts androgens into estrogens. It's not entirely clear why this occurs. Another unusual cause is an ovarian tumor. This is usually a granulosa cell tumor. On ultrasound or on examination, there will be a pelvic mass. The management of a pelvic mass is to surgically take it out. So that will be the granulosa cell tumor. So we have two causes which are gonadotropin dependent, two causes which are gonadotropin independent. This is your idiopathic normal MRI of the brain. When you look at this girl here, what does her body look like? A child or a teenager? And yet she's 7 years old. What I want you to notice is her height. 1 foot, 2 foot, 3 foot, 4 foot. She's about 4.5 feet tall. Short stature. So this idiopathic case is treated with GnRH agonists, which will suppress the FSH and the estrogen. Notice her height is very short. Here we have the girl who has precocious puberty, probably from a CNS lesion. She is much younger, 4 years of age. Notice her breast development, which is a reflection of her endogenous estrogens. And this will be managed according to whatever the cause is. This is a little girl who has a granulosa cell tumor. And here you can see the image. We're going to take that out. This is McCune-Albright syndrome. You can see the café au lait spots. This is another picture of the café au lait spots, the brownish pigmentation. Now, what other disease has café au lait spots? Von Recklinghausen's disease. You want to see a really serious case of that? Unbelievable. Okay, early puberty may put kids at risk, and they are at risk for being victimized. Certainly sexual abuse and incest is a big concern with precocious puberty. This is the youngest mother ever recorded, a 5-year-old Peruvian girl by the name of Lena Medina in 1940. And this is a physician who reported the case. So it appears to be well documented. This is a recent ethical dilemma that has been presented in the media. This is a severely mentally and physically disabled girl who her parents have been wanting to give her hormones to bring about premature closure of her epiphyses so she won't grow any bigger, so that she'll be easier to manage, just physically. Is it okay to stunt her growth? And we will leave this discussion to the ethicists. Okay, precocious puberty. We can look at this in terms of FSH being elevated or FSH being low. If FSH is elevated, we call this gonadotropin-dependent precocious puberty. If FSH is low childhood levels, we call that gonadotropin-independent. The most common of the gonadotropin-dependent is idiopathic. She's typically going to be 6 or 7 years of age. The findings are normal. There is normal head MRI. Management is GnRH agonists. If there is a CNS lesion, we're going to find this with a head MRI, which is abnormal. This is typically going to be less than 6 years of age, and the management will be individualized. If gonadotropins are low, FSH is low, ovarian tumor, pelvic mass on ultrasound, on physical exam, take it out. McCune-Albright syndrome, café au lait spots, treated with aromatase enzyme inhibitor. So, to summarize again, FSH elevated, gonadotropin dependent, is idiopathic and CNS lesion. If FSH is low, normal childhood levels, gonadotropin independent, that's granulosa cell tumor and McCune-Albright syndrome. Idiopathic is treated with GnRH agonists. CNS lesion is medical or surgical treatment, whatever is appropriate. Ovarian tumor is resected surgically, and McCune-Albright syndrome is aromatase enzyme inhibitors. And that is the end of precocious puberty.